All right. Good morning. If you can all enter your good mornings, please, as part of the roll. Thank you very much. Wow, you guys are quick. Look at them go. Now, up on the screen, let me know if you can see it wiggling. There should be a sequence of blood flow through the heart. Can everybody see that? Please type in I see. I see. Thank you. So everybody can see that. Just kind of want to draw your attention to that. Make sure everybody can see that before we begin. All right, today we're doing cardiovascular, and I should get to the flow of the heart and all that. EKG, I may not quite get to it, but if I don't, I will post a pre-recorded lecture for you to review. Now, again, I've posted the endocrine lecture because I don't think I'm going to get a chance to actually lecture on the endocrine, but I want you to review that content, and that should be available to you in Canvas. Wednesday, you have your chapter exam, and I hope you guys are studying up for that to do well. 35 questions. And it will be opening at 8:30. There's no lecture before or after. It's just the exam that day on Wednesday. Week after the midterm, which is coming up week after next, and then 2 weeks from now, you have your OIN exam. You'll be having your OIN exam. And so I want to make sure that you guys have started studying for that, because again, there's going to be a large amount of extra credit given for that. And that too will be administered during our Wednesday lecture time for that week. On the screen before you now, this entire sequence, we're going to review, but if you start committing this to memory, and this is available in Canvas, sequence of blood flow to the heart, it will help you to memorize the chambers and the valves and a few other details of the heart. Okay, so let me get to another screen share here. Get rid of that. Yeah, pull that one up. All right, now this new screen share should say heart anatomy. And this is the PowerPoint that we'll be doing today. Someone asked, is there a study guide? Is there a study guide for what? If you're asking if there's a study guide for the chapter exam, well, you've had it all along. If you're asking me, have I given you questions that will be on the exam? No, I have not. But your study guide is your lecture outline on all the content that is listed in the calendar. That's your study guide. You guys always have a study guide because all the content that's possible for testing is on there. I don't give out questions. Now, the exception for questions that I do give out are on the midterm and the final. Now, the midterm, you should have what you would probably call a study guide, but it's not all the questions on the midterm and not even all those questions on the study guide are there, but it will help prepare your mind for how you need to think and maybe help give you some direction as to how to study for it. And again, that's available in Canvas. All right. Now, pulmonary and systemic circuits. On the screen, we see that the right side of the heart and the left side of the heart. So our heart is a pump, and there's a left side and a right side to it. The right side receives oxygen poor blood. Left side receives oxygenated blood. So that's something you've got to get straight in your head. Oxygen poor blood returns to the right side. Oxygen rich blood comes from the lungs to the left side. Now the heart is a pump, so it's got to make sure that all of the blood is circulating with each circuit. The right side is going to pump blood to the lungs for oxygenation. The left side is going to receive the oxygenated blood from the lungs and has to make sure that it goes clear from the nose down to the toes and back again. The chambers are the right atrium, left atrium, right ventricle, and left ventricle to the heart. This diagram here just shows us a schematic of the heart in the center where my cursor is moving with the blood flow. It is colored blue and red. Blue indicating oxygen poor blood, and the red indicating the oxygen rich blood that's returning from the lungs. And then we see it in the systemic circuit where it's traveling to the rest of the body for oxygenation and then to return carbon dioxide and other metabolites. So the size, location, and orientation of the heart. Heart weighs less than a pound, and it's about the size of your fist. So if you make a fist, that's about the size of your heart. If you work out and you're aerobically fit, it's going to be bigger than that because physical conditioning does cause a hypertrophy of the heart so that it can become a more efficient pump. And we'll talk more with regard to that in Starling's law of the heart. It's located in the mediastinum, and the mediastinum is again between the lungs. It's on the superior surface of the diaphragm, so it sits superiorly to the diaphragm. 2/3 of the heart are to the left of the midsternal line. And up here on the screen, you can see what that means exactly. So here we have our midsternal line, and here we have the location of the heart deep to the sternum and protected by the costal struts of the thorax here. Where my cursor is moving on the screen is the diaphragm that you see here. And of course, the diaphragm is the border between the thoracic and the abdominal cavities. This transverse section shows us the location even further with the placement between the lungs in the mediastinum or the mediastinal cavity with the heart here. For orientation for the posterior, we have the vertebra, and anteriorly, this slip of bone that we see here is the body of the sternum. The heart has a base and an apex. The apex is actually the tip of the heart here, as you see the cursor on the screen. So this would be our apex for our heart, and this would be our base. The base is where all the great vessels of the heart are coming and going from. Now, the pericardium, and I'm going to refer to my lecture outline, coverings of the heart, the pericardium. And we have a parietal pericardium and a visceral pericardium. And then there's a fluid. The parietal pericardium is the superficial, and it's also known as the fibrous pericardium. The visceral is the deepest layer, and this is the one that's going to be adherent to the surface of the heart itself. In between the two, you're going to have this cavity, the pericardial cavity, and there's going to be a fluid, a pericardial fluid. And the pericardial fluid is there as a lubricant, so that each beat of your heart is lubricated with this. Now, the pericardial sac protects the heart from infection. Unfortunately, if it does become infected, this is when you get a pericarditis, an inflammation of this membrane. And the inflammation and infection can be so bad that the pericardial fluid becomes replaced with pus. And I have seen this during autopsy where I've opened up a pericardial sac, and instead of finding the normal fluid from which to take a sample, it was just a milky yellowish pus that was there. And so this, and of course, is what took out that particular patient. On the screen, we can see the layering here of the fibrous pericardium, the visceral pericardium, which also forms part of the epicardium to the heart. The heart has 3 layers, and so this is indicated here on the screen where my cursor is moving of the heart wall. So the outer part, the outermost layer of these 3 layers of the heart is the epicardium, the myocardium, and then the endocardium. And then we have the chamber itself. The myocardium, please note, is the thickest of these 3 layers composed of cardiac muscle. Endocardium is characterized by the texture of the folds. On the screen, you can kind of see this shadowing in here that's indicating a textured inner surface. And so this surfacing is characteristic to the chamber. So in the atria, the endocardium is textured into what we call pectinate muscle. And in the ventricles, it is textured in what we call the trabeculae carnae. And so we'll elaborate on that in a bit here. This just kind of goes through what pericarditis is, what I just spoke of. And this just recapitulates the 3 layers of the heart wall, epicardium and myocardium. And we're going to get to the endocardium. Now, realize that the heart, made of cardiac muscle, it occurs in bundles, but these bundles also form like a ribbon or a sheet, as you see here in the diagram, that wrap around the heart. And this is what gives this heart, this is what gives everybody's heart that capacity for contraction, and that your heart's not just sitting in your chest, contracting and relaxing, just It's a wave of contraction that passes over the organ, back and forth. ensuring that blood is kept moving through the chambers. All right, let me see my screen here. Now, separating the two atria is what we call the interatrial septum. And it has this feature called the fossa ovalis, which is a remnant of the foramen ovale of the heart. The foramen ovale is the hole that is there during development. So every baby is born with a hole in its heart. But on its birthday, that hole closes up and begins the circulation pattern of an adult heart. Prior to that, this hole, the foramen ovale, facilitates blood passing from the right to the left right away without having to go to the lungs, because of course your lungs aren't exchanging any air because you're in utero. The baby's air comes from oxygenation provided by the placenta. And we'll get into that circulation in a bit. On your birthday, this hole closes and forms a scar called the fossa ovalis. So the fossa ovalis is very much like your navel. It is a remnant from a developmental period prior to birth. And so both the navel and the fossa ovalis are normal scars in a human. Now, sometimes baby's heart doesn't close all the way on the day of its birth. And so then they keep an eye on it because sometimes it closed just a little bit later. But if it doesn't close soon after birth, when I say soon, I'd say that's about a week or two, then they become concerned and start exploring the option of perhaps surgical correction to help close that. Because by keeping that hole in the heart, you're not going to get a proper circulation pattern. And so this will be detrimental to the development of the child. The interventricular septum separates the two ventricles. So here we have a heart, very nice diagram of our heart schematized. Here are the great vessels. Let us identify the great vessels, the superior vena cava, inferior vena cava. Both are colored blue, indicating the presence of deoxygenated blood. They are on the right side, and so are returning deoxygenated blood here to the right atrium. In the wall of the right atrium, we see here the fossa ovalis. Highly textured here are the pectinate muscles, that specialized endocardium of the atrium. So you can see the pectinate here. Here we have the right ventricle. Blood passes from the right atrium into the right ventricle and passes over the first of the four valves. There are four to the heart, and this valve is called the tricuspid valve. Tricuspid valve is found on the right side. The bicuspid valve, you see where my cursor is moving, is on the left side. It's also known as the mitral valve, the bicuspid valve. In order to memorize this, an easy mnemonic, just remember tri-right. And you'll always remember that the tricuspid valve is on your right side. So blood passes from the right ventricle into the left ventricle over this valve. Note that the valve is anchored into the wall at what we call papillary muscles. So these little extensions right here are papillary muscles. It's indicated here on the right, on the left side, but these are also papillary muscles here. The cords that are the anchor for the valve are called the chordae tendineae, the chordae tendineae. And this helps to ensure that the valve doesn't blow backwards into the right atrium when the right ventricle contracts. Note the high texturing of the right ventricle, indeed, and the left ventricle as well. This texturing is called the trabeculae carneae. Trabeculae carneae. What does that translate out to? Trabeculae carneae. Well, trabecula mean folds in Latin, and I'll type that into the chat box. Trabecula equal folds. What does carne mean? It's the same meaning as in Spanish currently. So what does carne mean? Anybody? Very good. Carne means meat. It means meat. So the translation of this term, trabeculae carneae, simply means folded meat because it's so textured. Now, why? What is the mechanical advantage to your body having invested so much resources and design to having this highly textured surface in the atria and the ventricles? I'll ask you to type in the chat box shortly, but I just want you to start thinking, why not just have a purely smooth wall? Why all these texturings? So think about it for a little bit. Again, note the presence of the interventricular septum here that separates the two. Also note on this diagram where my cursor is moving, here we have the wall of the right ventricle, and here we have the wall of the left. Note that the wall of the left ventricle is a lot thicker than the wall of the right. Remember, the right ventricle is moving blood to the lungs, and that's like where my cursor is moving into the pulmonary trunk, and the pulmonary trunk gives rise to the pulmonary artery, going to the lung where the blood can be oxygenated and then returned through the pulmonary veins to the left atrium and then on into the left ventricle. The second valve is our pulmonary semilunar valve. Note, this valve has no chordae, only the atrioventricular valves, which is another name for the tricuspid and bicuspid valve is atrioventricular valve. So I'll type that word in too, atrioventricular valve. So the semilunar valves have no chordae, but they serve in the same effect to prevent a backflow here, keep the blood moving in a single course. Now, arteries and veins. Now, the definition of an artery and vein, the hard anatomical definition is that arteries carry blood away from the heart and veins return blood to the heart. That's just a hard definition. Now, most arteries in the body are going to carry oxygenated blood, and that's why they're colored red, but not here. This pulmonary artery is blue because it's carrying deoxygenated blood. In addition, note the pulmonary veins. All veins in the body are going to usually carry deoxygenated blood, but not the ones in the heart. The pulmonary veins are going to have oxygenated blood returning it to the heart. So this is a big exception with regard to the blood within these vessels regarding the heart. Again, pulmonary artery carrying deoxygenated blood and pulmonary veins carrying oxygenated blood back from the lungs. And again, if you speak Spanish, pulmonary is easy to remember with regard to circulation to the lungs, because of course, what are the lungs called in Spanish? Anybody? Put that in the chat box. Pulmones, very good. Pulmones. That's the name of the lungs in Spanish. And so you have this conservation of the meaning from Latin into Spanish with regard to this. So this might help. All right. And I'm just taking a quick peek here. All right. So we identified the vena cava. The auricle, I'm looking at the right atrium on my lecture outline, and coronary sinus. I'll show you a picture of the coronary sinus in a bit. The auricle is this small appendage found on the exterior of the atria. So we have both a right auricle and a left auricle. And let me see if I can find a picture with that. The sulcus is just that fold. It's a groove found on the surface of the heart. And it's going to have within it some of the coronary vascularization. So here we have an intact, not a cutaway view, but an intact surface view of the heart up on the screen. And we can see the presence of the auricles here. So this is our auricle of our left atrium, and it's like a little floppy structure. Auricle. Where did we see auricle before? Where did we see auricle before? Anybody? With the ear. Very good. And so the story is that one of the first anatomists who were looking at the heart centuries ago had a brand new puppy dog, and that little puppy was running around the lab, I suppose, the dissection lab. And he noticed that its little ears were flopping up and down as it was joyfully running around. And it reminded him, this part of the heart, of his new little puppy's ears. And so he named them the auricles. Here we have the coronary vascularization running through the sulci on the surface of the heart. Note the presence of an abundance of adipose tissue. This is normal on the surface of the heart. Hearts that have no adipose are a starved individual. So it is normal to have some fat on the surface of the heart. Let me draw your attention here between the aorta, and we're going to talk about the aorta, and the pulmonary trunk. There is a ligament called the ligamentum arteriosum. The ligamentum arteriosum. This ligamentum arteriosum used to be an open blood vessel called the ductus arteriosus. Called the ductus arteriosus. This was a vessel open during gestation, open during the fetal period in the womb. And this allowed a bypass as well between the pulmonary trunk and the aorta, bypassing blood flow from the lungs and shunting it into the aorta. On your birthday, this closes off as well as the foramen ovale that was here. So there's two bypass structures that close off on the day of your birth. The foramen ovale becoming the fossa ovalis, and then this ductus arteriosus will now close off and become this ligamentum arteriosum. And so the way they close is like, okay, well, how does it know to close? Some of you might ask. The blood pressure. An increase in blood pressure causes these to close off, and they're supposed to close off so that now blood is going to be shunted to the lungs so that as you breathe, you're going to blow off carbon dioxide and take up oxygen, and then it's going to be separated best. And this is why it's good to hear a baby crying on the day of its birth. You want to hear a good, strong cry from a baby because that means its blood pressure has gone up. And this was the reason why they used to smack the child's backside on the day of their birth, not just because it's a good luck whack or something like that, but it's to drive up the blood pressure. I mean, imagine here you're being born, you're being torn out of your comfort zone. All the nice warm liquid has been drained away. You've been squeezed out of your home. Now you're in bright light. The temperature has suddenly gotten colder. And then you get a smack on the backside. That's enough to cause indignation in anybody. And so what happens? The baby's blood pressure goes up. I'm upset. I am not happy. Blood pressure go up. And the next thing you know, it wants to let everybody know how unhappy it is. And so it lets out a squall. And in order to continue squalling and letting people know, it has to breathe. So then you start getting the air into the lungs. And of course, the baby's going to be spitting up amniotic fluid to get it out of the lungs, and that's okay. So the birthday is a really traumatic and hard experience, not just for the mother, but for this new little life. And so it's like, happy birthday, kid. Welcome to the human world. All right, let's see. Left atrium, left and right pulmonary veins. Now, the pulmonary veins, again, are returning oxygenated blood to the left side. And if we move further here, what we're looking at here is a posterior view. And here's where we have that coronary sinus that I mentioned. It's bigger than a vein in that it's a chamber on the posterior side of the heart where the deoxygenated blood is drained away. Again, you notice the vascularization on the surface of this heart with regard to the coronary arteries and coronary veins. A heart isn't just absorbing, it's not capable of just absorbing its own oxygen supply and nutrition from the blood that's being moved within it. No, it has its own vascularization such that you see here. Well, in order to facilitate, in order to help the drainage of the blood from the heart, you have this collection chamber called the coronary sinus. Up here again, we have present the pulmonary veins, right and left, that we see here. And of course, they are colored red, indicating the presence of oxygenated blood. Here we have our pulmonary vein arteries that are colored blue, carrying our deoxygenated blood to the lungs. All right, let me see here. Yeah, now. In the lecture outline, I've broken up the characteristics of both the atria and the ventricles. And right now I'm looking at the ventricles with the right ventricle and the left ventricle that we see here. Again, I made note of the papillary muscles that are the anchor points for the chordae tendineae into the trabeculae carni. And again, the trabeculae carni is the specialized folding of the endocardium of the ventricles. And I discussed the pulmonary trunk that's going to be carrying the blood away from the right side into the lungs. And there's going to be a valve there, that pulmonary semilunar valve. Left ventricle, it is thicker walled than the right. I showed you that. And it too has papillary muscles with chordae tendineae anchoring down that bicuspid and mitral valve. It too has trabeculae carne, but the vessel coming off of the left ventricle to carry oxygenated blood now to the rest of the body is the aorta. And we have the aortic semilunar valve. And let me see if I can get back to a picture of that. Zipping back. So here we have a section through that heart. Here we have our aortic semilunar valve. And again, note there are no chordae here. Yes.
You froze again.
Okay, so my screen, it's not moving?
No.
Okay. All right, hold on. I'll be right back.
Do you know what page we are on the outline?
Okay, I am back and let me see about my share screen here. All right, let's see, cardiovascular PowerPoint. And that's where I want to be. Let me see if I can get back to the heart anatomy here. Oh, let me see here. I can get back to that. Ah, there we go. All right, can you guys see the screen zipping through now?
Yes.
Okay, good. All right, so let me get back to where I was at. Zip, 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 zip. All right, let me see here. And where did I leave off here? Let me see. Lecture outline. Okay. Da, da, da. looking into the lecture outline, and maybe I'll show you what I was talking about with regard to some of this vascularization, because I have a list for you to memorize. Of course, I have a list for you to memorize. All right. Okay. There we go. All right. So let me switch my share screen here really quick. So let me stop that share. So I've stopped that share. And I'm going to pull up another share screen here. Here we go. The share screen now should show you your lecture outline. And this is at the end of the lecture outline for the heart. The last page is the vascular patterns of the human body. And in it, I have these boxed areas that are very much like those boxed areas for the muscle. In that for the midterm, you're going to have to be able to memorize the placement of these vessels with the major vessels that you see that are the branches. Somebody has their microphone on. Could you please turn that off? Thank you. Here we have the ascending aorta, abdominal aorta, aortic arch, and so on. These vessels are what are coming off of these branches of the aorta. And so for the midterm, you're going to have to be able to match them with their major vessel. For instance, the bronchial arteries. AA just mean arteries when you see it up here. That's coming off the thoracic aorta. Coronary artery, left and right, are both coming off of the ascending aorta. The aorta has 3 parts. And so if I get back to this share screen now, hold on. All right, the share screen up on the screen should be of the heart. Everybody see a heart on their screen, moving, wiggling around? I wiggle it.
Yes.
Yes, okay. Note, where was I going with this? Oh, I just had a thought and I've lost it. Ah, the aorta, parts of the aorta, that's it. So if I enlarge the screen, here we have our aorta. It's got 3 parts. The ascending, which we see indicated here. The arch, which we see here. And then the descending aorta, which we'd see more on the posterior part of the heart. We really don't see it here on this side in this diagram. So here's our aortic arch, and then it would be opening down here, descending this way. The aorta is the largest artery of the body. It's really big. And in some humans, depending on how big you are as a human, it could be as big as some of the air hoses in a car engine. That's how big it is. And it's such a big vessel that it has its own vascular supply, meaning it has its own specialized blood vessels that supply it with blood. All right. So I was done with that share screen. Okay. Now, on the lecture outline, I also had prior to the page I had shown you, were the adult corollaries of important embryological structures. And so you'd have to be able to match these structures one with the other. And on the list, I have ligamentum arteriosum, which was the ductus arteriosus. I have the fossa ovalis with the foramen ovale. But I've also got several other ones like the ligamentum teres, used to be an umbilical vein. The median umbilical ligaments used to be umbilical arteries and so on. So we have several vessels that change into ligaments on the day of your birth with that increase in blood pressure. And this, of course, is to shunt the blood into an adult pattern of circulation. Now, just a little bit about vessels before I continue on here, is that there are 3 layers to all arteries and veins. And on my lecture outline, I even have arteries and veins with that anatomical definition about all arteries carrying blood away from the heart and veins carrying blood to the heart. Then I have the 3 layers that are listed, the tunica externa, tunica media, and tunica interna. The tunica media is the thickest layer in the arteries and veins, and it is made up of smooth muscle. So you have this wall of smooth muscle, and the smooth muscle that runs throughout all of your major arteries and veins is a contributing factor to your blood pressure. Some diseases are such that if they affect the contractility of the smooth muscle, can give you chronic hypertension. Hypertension, of course, is high blood pressure. And hardening of the arteries, arteriosclerosis, is one of these, in that you get this buildup of calcium on the inside of your heart, and it extends from the tunica interna on into the tunica media and causes the smooth muscle to freeze in enough areas. What's frozen? I'm not moving anything. So can you still see the screen wiggling?
Oh, yes. I didn't know if you had switched to a different.
I haven't switched yet. I'm just talking because I'm talking about the lecture outline here. All right, so that's one factor with the arteriosclerosis, is that it can affect the tunica interna and the tunica media. All right. Now I'm looking at my outline, and I'm looking at, okay, we talked about the ventricle, trabeculae carne, and the aorta. All right, before I move on to the valves in particular, remember I had asked you a little earlier why the heart, and now I'm zipping back with my PowerPoint, so you should see the screen moving. All right, so right now I'm back to a coronal section of the heart, showing the pectinate muscles and the trabeculae carne. Again, what is the advantage to having this highly textured endocardium to the heart itself? Why not smooth surface, you know, to move to the blood? Why? Anybody? Okay, someone says its ability to expand. Well, yes, that feeds into it, but anything else? What would texturing cause as you're moving a liquid through it? What do you think all that texturing would cause? Starts with a T. Starts with a T. Anybody? Well, yes, a healthy texturing is a strong heart, but what would it cause? No, well, tachycardia. Tachycardia means it speeds up your heart. We're talking about an advantage to the flow of the heart. No, the word I'm looking for, although I can see, you know, that this is with regard to the heart, so good effort. It is turbulence. turbulence. These text strings provoke a turbulence to the flow of the blood in the heart because you've got blood coming into these chambers, and we want to make sure that it exits these chambers efficiently without leaving one blood cell behind. Because if you start leaving blood cells behind, what do you think would happen if you had like maybe a weakened heart? And let's say that this part of the heart wall where my cursor is moving, let's say that this part of the heart wall wasn't so strong as the others, and you began to get a little pooling of red blood cells here. What would that eventually cause? What would that eventually form? Anybody? You type in the chat box. A thrombosis. Yes, a thrombosis. A thrombosis is what we would commonly call a blood clot. A thrombosis occurs within the closed circulation system. An actual clot is what occurs when the blood is exposed to the air on the outside. So an internal clot, as you will, within the circulation is called a thrombosis. And so, yes, and so is a thrombosis compatible with a good clinical picture for a patient? Is that something desirable, I should say? No, it is not desirable. We don't want clots circulating within us. And so having this texturing and having good, strong contraction of the heart ensures that such a thing doesn't occur. And in fact, in the creation of artificial hearts, this is one mechanical problem that is still resulting in a failure of being able just to use mechanical hearts instead of an actual donated heart from actual humans in this regard, in that our mechanical hearts all have like a smooth lining. They haven't designed one yet with an efficient texturing, as you see here, where we're not capable quite yet of doing that. So very good. You guys are thinking. All right. Now, the valves of the heart are what produce the sounds. And let me see if I can get down to something like that here. So I'm zipping through the PowerPoint real quick here. So let me see. Let's see if we have our pictures. All right, I'm zipping past an actual heart that you see here up on the screen. Again, you can see the presence of the pectinate muscles in the atria and the trabeculae carnae in the ventricles. When we dissect the sheep heart look very similar to a human heart. You're going to have to be able to identify for the practicum coming up if we're looking at an atrium or a ventricle by the presence of the pectinate versus the trabeculae carnae. And you look at a couple of hearts, you will be able to tell. You will. And okay, that just shows us all open with the great valves. I'm zipping through because I'm looking for a valve. Here we go, heart valves. All right, we talked about the atrioventricular valves and semilunar valves. And here we have their placement through the heart. When you make a certain oblique cut through the heart, you're able to see in single section their presence. And so we see them here. So as these valves close, this is what is going to produce the sounds that you hear. that lub-dub on a person. If you don't know what that sounds like, get somebody you love and listen to their heart. And just say, can you just lay there real quiet and let me hear? And so, or you have a stethoscope, you can hear the sound of these valves opening and closing. And that's what your heart sounds are. There's a great meme I've seen online. Well, I don't know if it's actually a meme or a joke, but it says that, there's a couple laying in bed, a heteronormative couple. The guy's laying on his back and his girlfriend or wife is laying up on his chest, and she's laying with her head, on his heart, and he's thinking, oh, how sweet. And they're just talking. And then all of a sudden, she's just asking, and then she'll say, like, have you ever cheated on me? And the thing is, of course, that, he has or he hasn't. If he has, what's going to happen to his heart rate? What's going to happen to your heart rate, man, if you're going to be asked something like that? And this is going to be an instantaneous reaction to stress. You get an adrenaline rush. When you get an adrenaline rush, what happens to your heart rate? Anybody? It starts pumping fast. That's right. We get a tachycardia. And so, do you think the girl has her answer then? With regard to your question. So I can see you ladies putting your anatomy and physiology knowledge now to work, huh? I don't know. But yeah, it's an instantaneous change. And so it's reflected in that sound. Now, a murmur on a heartbeat is when there's a leakage to the heart valve. So instead of that crisp lub-dub, you're going to hear a lub-dub, lub-dub. Or if it's like a complete failed valve, you're not even going to hear the lub-dub or the lub-dub. You'll hear like a dub. And if it's like totally off, all the valves are messed up, and it's going to sound like an unbalanced washing machine. You're just going to hear. And I can make these sounds because when I was learning and I was in medical school, one of our tests, when we went over the heart and we're learning medical practice with regard to the heart, was we had to be able to sit and listen. And this was part of the testing process. They would play a recording and we had to sit there and be able to write down the description on our test book of this recording. And if this was a normal heart, or if what we were hearing was a murmur, and if it was a murmur, we had to try to evaluate to what degree, like which valve it was. And so this was part of the training, because you want a doctor who can be able to listen to your heart and not just tell that something is off, but you want them to be able to quantify it and be able to tell you like what's going on with regard to the failure. Now, there are two types of main failure to the valves that are going to cause a murmur. One of them is arteriosclerosis. You can get buildup of calcium causing a plaque on these valves so that they lose their pliance and they become crunchy. I mean, I've seen valves that came in from surgery in the pathology lab that I could pick up in my fingers, and they were so brittle, I could hold them in my fingers, gloved hands, and break them like it was a cornflake. That's how bad the calcium was. A normal heart valve should have all the pliance of, like, let's say a cooked piece of pasta. It just kind of gives, it's wiggly, strong in that way. Another cause of a heart murmur is infection. Now, on the screen, you see where my cursor is moving on this screen. You will get vegetations vegetations. And these are going to be growth of either bacteria or fungus. And I'll type that. Vegetations. And they call them vegetations because they actually look like a little piece of vegetable. They're textured and kind of knobby looking, like a little piece of broccoli or a little piece of cauliflower that's just sort of growing there. And of course, this is going to spread not just from one valve, but it's going to, take hold and could be seeded and grow on the other valves as well. And so this is also going to necessitate valve replacement. Fortunately, they seem to have got this down in cardiovascular surgery that you can replace heart valves. And they even now have procedures where they don't even have to crack you open. You don't have to open up a patient's chest and open up the heart directly. No, they can take a catheter with special instrumentation and thread it through your femoral artery, through your leg, making a small incision and threading it up into your heart. And the placement of this catheter delivers a new valve. So they're able to go in, cut out and remove the defective valve, and then reinsert the new valve in place and secure it without having to open up the chest at all. It's remarkable. And they've only been doing this maybe in the last 10 years. With this. So this is a new procedure, and they're kind of been ironing out the bugs from it. Now, there's two types of valves that you can get. There is artificial valves, and then there's animal tissue valves. Animal tissue valves will come either from a pig or a cow, depending on what your size is. And these are going to be the actual tissues. And so they're going to behave much like your own valve in their placement, and they'll be silent. I mean, you can't really hear your valves unless you listen closely to the chest. A mechanical valve is going to make a noise like a small click, so that every time your heart beats, you're going to hear this click. And a lot of people don't want the animal tissue, and they go for the artificial ones because they do give you a choice. Both types of valve replacement require you to go on blood thinners, but you have to have a higher amount of blood thinners for the mechanical valve, because every time that thing clicks, it's going to destroy a certain amount of red blood cells in the area. It just can't be helped. Now, my own personal experience with a mechanical heart valve is like when I was in the 4th grade. I had this teacher, and his name was Mr. Seplak. God bless that man's memory. He was a great teacher. He was the kind of teacher that would find out what your interests were and then give you a gift based on your own interests. So like at Christmas, when we were in his class, he gave all his students something. I got a book on science because I was really into science. And my friend at the time, my best little friend at the time, his name was Louis. And Louis was into boxing and wrestling. I mean, that was just his thing. And so he got him like this little pair of boxing gloves for him. Anyway, this man, Mr. Seplak, when he started the school year, told us, class, I have a heart condition and I have an artificial valve. And so sometimes you might be able to hear it just like now. And so we all got real quiet, and sure enough, you could hear a clicking, a light click, like it was so soft, but young ears can pick it up, and it sounded like a clock, just regular tick, 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 tick. He goes, I have medication, so if I look dizzy or if I pass out, you can help me and give me one of these pills. And so he had this medication in his pocket. And so we were all like, oh my gosh. And so we were the quietest little class. And my little friend and I would sit there and be doing our work. I'd be like, Louis, Can you hear it still? Because Mr. Seplack would sometimes nod off, like he'd be taking a nap, and we're all real quiet. So we're listening. We're like, yeah, I can still hear it. So yeah, he's not dead. Okay. So I'll remember that man and his heart valve to this day. All right. Let's see. Now, the coronary arteries come directly off of the ascending aorta, the ascending aorta. And so that's a question I like to ask, where do the, coronary arteries come off of? And it's the ascending aorta. And so the heart is the first organ that receives its supply of oxygen and nutrition. It's the first oxygenated and nutrified organ of the whole body, because really if the heart goes offline, then that's it. It's, everything has to shut down with it. Now, I'm going to jump over the conduction system of the heart because that's a different little lecturette with its own PowerPoint. And I'm looking at my time. I might be able to get to it. Okay. But I wanted to make sure to cover Starling's response, Starling's law of the heart. So this is with response to exercise, and that's at the top of the page, one of the lecture outlines, just over the arteries and veins content. Starling's law is the relation between the increased preload to stroke volume. Okay, what does that mean? Increased preload to stroke volume. Okay, well, when your heart beats, it's delivering a volume of blood. With each beat, it's delivering a volume of blood to the lungs, and then it's delivering, of course, a volume of blood to the rest of your body. Increased preload means that when you have a demand for increased heart rate for flow, you're going to return more blood to your heart. Now, you start working out, okay, and you notice that when you work out, your heart rate goes up. When you continue to work out and become aerobically fit, you notice that your heart rate decreases over time, but you're able to exercise and do more. And how is that possible now? Let's think about this. And you've seen this if you go to the gym, you see people when they work out and they're holding like their finger up against the carotid artery in their neck, right? Have you guys ever seen that? And what are they counting? They're counting their heart rate because they want to know what their heart rate was before they started working out versus after. Because over time, you're going to notice that you're not going to have such a huge increase in your heart rate. So what has changed that your heart has been able to beat less, but obviously become more efficient because that result of being aerobically fit is that you're able to exercise harder and for longer periods of time. So what has happened? Your heart will hypertrophy. The wall, especially of the left ventricle, will hypertrophy. And so will the wall of the right, but more on the left. This hypertrophy means that the heart's getting bigger and means the chambers are getting bigger and can hold more blood. So rather than having to work really hard and beat all of this blood, it's become more efficient in that the chambers are now bigger. And so the stroke volume is higher now. And so this is why your heart rate isn't as high after you're aerobically fit. And you can see this, someone who's really aerobically fit, there's not much difference between their resting heart rate and, you know, after like an hour of exercise. I mean, if it's high, it comes down really quick versus someone like myself. Oh my God, 5 minutes on the treadmill and my heart rate shoots up from 70 to like 180 beats a minute. I mean, it's just like boom, 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 boom coming out of my chest. Other people, it's like no big deal. You know, they're not even really breathing hard. This is the reason why, Starling's law. And so that's why it's in response to the heart rate. And again, blood pressure, because your blood pressure accommodates for this as well. So that's kind of like the anatomy and a little physiology behind becoming aerobically fit. And again, any questions or comments, put them in the chat box. All right. And let me see what else here. No. All right, what I'm going to do is I'm going to switch away from this screen. So hold on. So I'm going to stop the share. So now you shouldn't see anything. Stop that screen share. And I'm going to look for another PowerPoint that's in your Canvas shell. Let's see here. I can find it. Oop, that disappeared. Okay. All right, I found it. Let me see if I can get back to my screen share. All right, on the screen, you should see the electrical events of the heart. Can you guys see that? Am I screen sharing that? Just type in
Yes.
IC or say IC. Can you guys all see that? Yeah, okay. All right. So your heart is going to produce an electric signature that is unique in all the world. It's so unique, people use it, you know, as a logo for a lot of biomedical corporations, companies, even pharmaceutical companies, ambulance services, etc. And you've all seen this. And the waveform is greatly outlined and identified. On your lecture outline, you notice that I had typed in bold TQRST. That acronym are the identifying peaks to this waveform, this electrical waveform. And let me see if we can find the picture of it really quick here just to show you. So I'm zipping through the screen really quick. This PowerPoint really does give us a lot of physiology. I'll come back to that particular screen. Hold on, let me see. The waveform, the EKG waveform, here we go. So up on the screen, we see the electrocardiogram right here. Now, you do not have to identify.
The screen is frozen.
You don't see the electrocardiogram moving in front of you?
No.
Oh, okay, let me see. Okay, let me try it again, hold on. Oh, it has frozen. Okay, give me a moment. Okay, I'm back and I've got to get that screen back. So just hold on as I get back in here. Find that PowerPoint and get into it again. What I'm looking at is the EKG PowerPoint. Calling that up. So I'm getting back to that waveform. All right, share screen. There we go. All right, can you guys see that waveform, the electrocardiogram? Wiggling up and down. Y'all see that? All right, people see it. Good. So looking at the screen, you have to know the P, Q, R, S, T, be able to identify those. You do not have to identify intervals or segments. And in physiology, though, you will have to learn how to measure these and apply it to different word problems. But in anatomy, what I require you to know is to be able to identify the elements of the waveform and to know what they mean. For instance, the P wave is for atrial depolarization. Now, depolarization is an electrical event. The QRS complex that we see here is the ventricular depolarization, And then the T wave is the ventricular repolarization. Now, all of this, again, is the electrical event of the heart. The mechanical event that these are going to produce are that at atrial depolarization, the mechanical event will be the contraction of the atria. At ventricular depolarization, the mechanical event will be the contraction of the ventricles. At ventricular repolarization is going to be the reset and relaxation of the ventricles. Now, the atrial repolarization event occurs very close to the Q event. And because the QRS complex is so huge, we don't really get to see the atrial repolarization event on an EKG. Now, the EKG is produced at each and every beat of your heart. It is a standardized test called the electrocardiogram. That's given to just about everybody, especially if we're going in for any type of procedure. On the screen here is the conduction system. And so let's go over the elements of this. All right, we have an SA node in the upper wall of the right atrium. We have an AV node in the floor of the right atrium. We have this bundle, and it's called the bundle of His, the atrioventricular bundle. And again, all of these are neurological features and tissues. Within the ventricular septum, we have a bifurcation of the bundle of His into what we call the left and right bundle branches, as we see here. These bundle branches terminate and produce this subendocardial conducting network composed of Purkinje fibers. Purkinje fibers. These are different than the Purkinje cells of the cerebellum, I suspect. They're named the same because I think the anatomist who discovered both of them is named after. So we have these Purkinje fibers and they're spread through the wall of the heart here. So we get depolarization of this SA node and it spreads through the atria and then triggers the AV node, and that AV node then triggers and sends the pulses through the rest of the heart. And this is our own natural pacemaker, this conduction system. Now, if this conduction system experiences failure, either in this node, or even maybe here within the walls of the heart, then we begin to have a heart failure. And it can result in things like afibrillation, AFib, tachycardias, bradycardias, etc. What do they do now for this? I mean, it's really such a common, surgical procedure. I mean, it's so common, they don't even really consider it serious surgery anymore because it's so standardized. Excellent. Someone put in a pacemaker. Exactly. The placement of the pacemaker takes over your own natural conduction system, and you're able to get along just fine with it. I know that with it, you kind of think, oh, I'm on borrowed time, my life is over. But I've heard, because I've seen this in the office. When I used to take my dad had bad heart. And so I'd go with him on his appointments and stuff. And there was this one old guy in the office, and he was talking to the doctor, and you can hear him. And he's just standing right there. And he was going in for like his third pacemaker, you know. And so they were doing up the write-up and the prep for him. And he was like 92 or 94. And he'd had a pacemaker in him since he was like 60. So some 30 some years, you know, this guy has had a pacemaker, and it sounded like he's gone through one every 10 years. So they last about 10 years, and they have to be replaced because the batteries do wear out. And usually by the time that they wear out, they come up with new and improved models. And he looked pretty hale and hearty and everything. With regard to that, my dad had a pacemaker placed in him, but you know, he didn't outlive the life of his pacemaker at all. So, but that's just the way it is. You know, some people do very, very well with it as a result. Some people, it doesn't do very much for them. Yeah, someone just shared their father-in-law has a pacemaker and he's doing great. Yeah, so it's really a godsend, a blessing, you know, for those that it does work well for, to be sure. And again, just to remind you, it's called the practice of medicine, not, that's why medicine is an art, because you have to keep at it. There's no one way for one patient. No one treatment works the same for everybody. So, all right, time is up for today. I will see about putting up the EKG. Maybe it might give you a little more with this. Also, there's another PowerPoint with like a little video, I believe, in Canvas. So if you can have a look at that, that'll be good. All right. So we will see you on Wednesday. Yes.
I believe you had stated that you had posted an endocrine lecture for us to review, correct?
Correct.
Is that under module 7?
It's either 6 or 7.
Because all I see is a PowerPoint. I don't see an actual lecture posted.
You don't? Let me
No.
see. Let me just check real quick. So I'm zipping through. Let me see. Hold on. Let's see. Okay, module 7. Endocrine PowerPoint, endocrine lecture. Okay. And so check now.
Okay, give me just a second. Let me read.
If you're in the Monday lab, check now. And I'm checking all the other labs. So the Monday lab section, it's been opened. Okay. While it is there, I did not publish it. So I'm publishing now. So just give me half a moment here. And let's see. It is indeed module 7. And it should be open now.
Okay, it's there now on module 7.
Okay, and I'm just opening it now for section 872 and module 7. Okay, so now it's published. So everybody should have access to that now. Sorry about
Okay.
that.
Thank you.
Uh-huh. Anybody else? Any other questions? Because again, on Wednesday, you have your chapter exam. It will be opening at 8:30 in the morning. And you'll be given 45 minutes to complete it. You can start it at any time. It's supposed to close. Let's see. Let me just check real quick here. Dun, 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 dun. Before you guys go away. Let me see.
So will endocrine be on the exam, Professor?
It will, but the parts on the endocrine is that you will be doing matching
Okay,
of the hormone with the gland.
okay. And when you on the it says CT, is that to do with the cardiovascular? I know on the schedule it says CT. Is that
CT is the connective tissue that's
got
associated
it.
with the muscles.
Okay, got it. Okay.
Okay.
Thank
All
you.
right. Hold on. Let me look at your chapter exam real quick. I have it. I just haven't posted it. So let me just check real quick something. What I have got here for you. So yeah, a time limit of 45 minutes. It's going to open at 8:30 and it will close at 10 a.m. So this means that, you can start at any time during your lecture period, but you're only going to get 45 minutes. It's going to shut. So it's not like you're going to get the whole hour and a half. So you can either take it first off, or you have until like 9 o'clock, 9:15 to give yourself another, bit of study time if you need that in the morning. Those of you that are DSPS, you will have your accommodation. So look for your email that morning along with your password so that you can make sure that you have your time for it. Okay. Great. So we'll see you. Okay, question?
Yes, you said you were going to post a couple of midterm questions.
They've already been posted.
All right, thank you.
Uh-huh.
So the endocrine will be in the chapter exam, right?
Correct.
All right, thank you.
Mhm.
Professor,
Uh-huh.
I have a question for Wednesday's lab.
Mhm.
Do we bring our lab coats on that day?
Yes, because we're doing the brain.
Oh, okay, thank you. Just wanted to
Mhm. Mhm. All right. Everybody have a good day. Study hard. Goodbye. Bye.